A very good afternoon to all gathered here online. I am Dr. Shweta M, Assistant Professor at Minto Ophthalmic Hospital, Regional Institute of Ophthalmology, BMCRI. At the outset, I would like to thank the organizing committee and the scientific committee of Karnataka Ophthalmic Society for giving us this opportunity to conduct an instruction course on corneal endothelium. Firstly, I would like to welcome all the co-instructors of the course, Professor Dr. Nagaraju G, Professor and HOD, Department of Ophthalmology, Minto Ophthalmic Hospital. He'll be speaking on when to suspect endothelial dysfunction. Professor Dr. Suresh Prabhuchi, Chief of Cornea and Eye Banking, Minto Ophthalmic Hospital, Regional Institute of Ophthalmology. He'll be speaking on how to train a resident on endothelium. I also welcome Dr. Tanuja GP, Associate Professor, Department of Ophthalmology, MS Ramaya Medical College. Thank you, ma'am, for joining. I welcome Dr. Hari Prasad, Managing Director, Hebri Eye Hospital, Hebri, Udupi. Thank you. So, a brief introduction to the course. Please play video 1. Please play Dr. Shweta M, video 1. Good afternoon, everyone. At the outset, I would like to thank the organizing committee and the scientific committee of the Karnataka Ophthalmic Society for giving us this opportunity to conduct an instruction course on corneal endothelium. Why an instruction course on a single layer of cornea? That is because the corneal endothelium, known for its excellent biologic activity but a limited regenerative potential, has been a substrate for many surgical innovations and regenerative bioengineering. The aim of this course is to promote a comprehensive understanding of the corneal endothelium by discussing its structure and function, by knowing how to examine the endothelium, identify the endothelial dysfunction, and to add a note on specular microscopy, endothelial cell layer photography, and also to review the recent advances. The goal of the course is to promote discussion among young and experienced ophthalmologists. So I would like to start today's talk of the instruction course by discussing the corneal endothelium, applied anatomy and physiology. PAC6 gene. This is the gene for ocular development. By 5th week, the neurocrest cells, which are pluripotent, condense to form the secondary mesenchyme, which forms the corneal endothelium. The migrating neural crest cells in three waves, the first wave of which gives rise to corneal endothelium. Initially, it is double layer in fetal life, thereby gives, and later it converts into a hexagonal monolayer. And this monolayer secretes a Descemet's membrane, which is nothing but the extracellular matrix, which is clearly visible at the end of 12 weeks of gestational life. Initially, it is a banded zone. Later, it becomes, there is also an addition of a non-banded zone, which is posteriorly located. So at 5 weeks, there is migration of first wave of neural crest cells. At 8 weeks, a monolayer of endothelium is formed. At 12 weeks, a Descemet's membrane is clearly recognized on histology. And at 5th month, the tight junctions are complete and a barrier is established. At 7th month, it resembles the adult cornea in structure, but not in size. So why do we know about the embryology? That is to understand the disorders based on neural crest origin. Disorders of neural crest cell formation leads to craniofacial anomalies. Of that of migration causes anterior segment dysgenesis, and disorders of proliferation leads to ICE syndromes, and disorders of terminal differentiation leads to congenital hereditary endothelial dystrophy, PPMD, and Fuchs dystrophy. A special mention to Peters anomaly, which is the most common cause of central corneal opacity in pediatric age group. This is nothing but a posterior corneal defect, though not strictly a disorder of the endothelium only. It is basically some problem in the anterior segment. The mechanisms which are explained are intrauterine inflammation, defective central migration of the corneogenic mesenchyme, defective separation of the lens vesicle from the surface ectoderm, and abutting of the lens or the forward displacement of the lens against the endothelium. So this mechanism is important to understand and to surgically innovate some techniques to treat this anomaly. There are various case reports of removal of only the defective endothelium in the central corneal defect, thereby preventing a transplant in the pediatric age group. The infant cornea is blessed with 5 lakh neural crest derived cells which are 5 microns in thickness and 20 microns in diameter with a surface area of 250 microns. They are typically 6-sided hexagons. Why hexagons? It is the nature's creation which is most energy efficient and optimal shape to cover a surface without leaving gaps. What happens to the cornea from infancy to adulthood? There are 5000 cells per millimeter square at birth, which reduces to 3500 at 5 years, and in late adulthood it is 2500 per millimeter square. There is a 0.6% decrease per year, and the cornea reaches to adult size by 2 years. The average horizontal diameter reaches to 11.7 millimeters with a surface area of 138 millimeter square. Descemet's membrane is one significant structure which grows even after the age of 2 years. It grows till death. Because there is a continuous secretion of the extracellular matrix by the endothelium. So it increases in thickness from 4 microns at birth to 6 to 11 microns as the age progresses. So this is how the corneal endothelial cells reduce in number and increase in size as the age progresses. Why limited regeneration of the endothelium? This is called in vivo mitotic quiescence. It is due to cell contact inhibition due to the activity of P27, which causes an arrest in G1 phase of the cell cycle. This is attributed to high levels of TGF-beta 2 in the aqueous humor and a lack of injury-inducible cytokine stimulating pathway. And there are racial and geographic differences in the endothelial cell density. Various studies have suggested, and there is a common consensus that the Indian endothelial cell density is lower when compared to other parts of the world. So there are various imaging mechanisms to understand the endothelium better and better, like scanning electron micrograph, transmission electron micrograph, and immunofluorescence confocal microscopy. So what are the functions of endothelium? It is mainly to maintain the detergescence, that is the relative dehydrated state of the cornea, and to maintain the corneal clarity. One cannot discuss the physiological functions of the corneal endothelium without recognizing the contributions of David Morris. He invented specular microscopy to image the endothelial cells, described a mathematical model that became the basis for endothelial cell permeability. He described principles of fluorometry, invented the corneal pachymeter, and described barrier and pump mechanism. So this is the image of his own endothelium. Most of his works are speckled with the data of his own endothelium. Here you can see the endothelium which has a cell density of 2159 cells per millimeter square with a coefficient of variation of cell area of 23 and 64% of the cells are hexagonal. So what is a pump leak mechanism? This barrier and pump are the two important functions to remember and to give importance whenever we speak about the corneal clarity. So this barrier is created by the sheet of cells which are arranged without leaving any gap on the posterior surface of the cornea. The intercellular gaps are only 25 to 30 nanometers, which reduces to 2 to 3 nanometers when it comes to the apical junctions of the cells. But there is a small leak there. This leak allows only the nutrients and the metabolites to pass from the aqueous humor to the stroma, but not the excess fluid. So this is considered a good leak. And there is a pump mechanism which is nothing but the presence of sodium-potassium ATPase channels and the bicarbonate ions among the lateral walls of the plasma membranes. So when the leak rate is equal to the metabolic pump rate, the cornea remains in a relatively dehydrated state. So what is this barrier function? As I told, this is because of the arrangement of the sheet of cells on the posterior surface of the cornea. It depends on the number of cells and the integrity of the tight junctions. So how does an endothelium maintain the cornea in its normal state? This is because of multiple factors, like there is a reserve of cells in the peripheral endothelium so that the number does not reduce. So there is an increased peripheral endothelial cell density. There are tight junctions. There is a metabolic pump which is comprised of sodium-potassium ATPase channels and bicarbonates, and there is minimal apoptosis. What happens if there is an insult to the cornea? Corneal endothelium is the stromal edema. So what are the causes of insults? Low calcium irrigating solutions, exposure of the endothelium to low or high pH, that is the ideal pH is between 6.8 to 8.2, solutions with low osmolality, ultrasonic detergents, enzymes, low endothelial cell density, exposure of the endothelium to endotoxins and exotoxins, and diseased endothelium as seen in Feux and pseudophakic dystrophy. So when does it decompensate? From birth till death, there is a 50% reduction of the corneal endothelial cells, but it does not decompensate normally. So when does it decompensate is only after 80% reduction from the late adulthood, that is around less than 500 cells per millimeter square. So there is an interesting study by Armitage et al. Where they have predicted that the normal corneal endothelium should maintain clarity for 224 to 227 years if the human beings were to be alive for so many years. So this is the endothelial pump and barrier mechanisms. These are the sodium potassium ATPase channels. It is there are quantification of these channels also. It is estimated that there are around trillions of sodium potassium ATPase channels in the endothelial cell layers. So how does this pump mechanism work? This is the crux of the endothelial cell function. There are sodium potassium ATPase channels in the lateral walls of the cell membrane, and this is the most important enzyme, that is the carbonic anhydrase, which converts water and carbon dioxide to bicarbonate ions. So these bicarbonate ions and an increased concentration of sodium on the stromal sides, they produce a gradient, an osmotic gradient across the cell membranes. So this passage of ions, the smooth passage of ions, is facilitated by the sodium potassium ATPase channels. These are further fueled by ATP, which are produced by the abundant mitochondria in the cytoplasm of the cell organelles. So coming to the application of these endothelial pump functions and the barrier mechanism, it is important to know what is an ideal irrigating solution. The chemical composition of an ideal irrigating solution should be, there are two important factors. One is pH and the osmolality. pH should be between 7.2 to 7.4 and the osmolality should be around 305. So this is even more important in the present age due to the increasing use of intracameral drugs. What is the effect of drugs? Though we use so many topical drugs onto the cornea, the endothelium does not get affected by it. It is only a few drugs which directly inhibit the internal cellular mechanisms like carbonic anhydrase. This carbonic anhydrase, as I told, the importance of which is the production of bicarbonate ions, which are important for the barrier function. There is no effect with acute administration, but on a poorly functioning cornea, if it is administered for a longer time, the cornea decompensates. What is the effect of IOP? In a normal endothelium, a high IOP can compress the stroma. The classical example is a clear and a compact graft on postoperative day 1 after a penetrating keratoplasty. And in a marginally functioning endothelium with a high IOP as seen in acute angle closure glaucoma, there occurs epithelial edema. And in a poorly functioning endothelium with a high IOP, there will be stromal and epithelial edema. In low IOP, there is thick stroma but no epithelial edema. What is the effect of contact lens wear? It forms endothelial blebs visible by specular microscopy as small dark areas in response to stromal acidosis. This is seen soon after the contact lens wear, but it is usually reversible. But there are certain morphological changes like polymegathism and pleomorphism which are seen in long-term contact lens wear. I would like to conclude this talk by just showing two scenarios. The first one is a square penetrating keratoplasty, which is not done now, which shows a polymegathism. After a PK, this is the polymegathism of the graft. And on the top right hand is the desec graft folded with the help of a forceps and stained with alizarin red. As we can see, there is an extensive loss of the endothelial cells over the area where the forceps is held. So this sensitive is the endothelium. So there is a formation of vacuoles and a definitive endothelial cell loss here. Thank you. Thank you for your patient listening. Now I would like to invite Professor Dr. Suresh Prabhuchi to give his talk on training a resident to look at endothelium. Please play the video. Dr. Suresh Prabhuchi. I thank Dr. Sirish Nelviki sir for joining this instruction course. Thank you, sir.
Hello.
Please play the next video.
Ma'am, actually, video is not presented, ma'am.
No, it is there. Please check.
No, we have checked it through. Actually, it is not there. We have Dr. Nagaraju.
No. Before that, there is Dr. Suresh Babu sir's video. I've checked in the Google Drive. Please double check.
Yeah, just now
just wanted to go in
my
order.
coordinator just checked, ma'am.
This is the Minto ophthalmic hospital which has completed 125 years.
The voice is heard. I don't know. I can't hear.
Yes, ma'am, it's
All
audible.
slit lamp procedures are binocular procedures except two. One of them is examining a corneal endothelium using specular reflection. The other being optical pachymetry. The minimum magnification that is required to see a normal endothelial cell is 25x. Corneal gattaca can be seen even in 16x. So you need to have a slit lamp which has got a magnification of at least 25 or 40x to view a normal endothelial cell. General points before entering into examining a corneal endothelium is just like all other procedures, the room illumination should be dim. Make sure you have got a good slit lamp with good optics and the illumination is bright. The patient and the examiner should be in an ergonomic position. Initially, you require a very cooperative patient who remains still and steady. This procedure should be practiced on a few cooperative patients in your office before you try it out on the real patients. What are the parameters that are necessary to examine the endothelium? The width of the slit lamp should be 1 to 1.5 millimeters, and the minimum length of the beam should be around 3 to 4 millimeters. The illumination arm should be between 45 to 60 degrees. First, focus the corneal epithelium with 16x magnification. Observe the bright filament light which is falling on the cornea. The slit lamp beam then should be aligned just adjacent to the bright filament. Once the corneal epithelium is focused, then increase the magnification to 25x or 40x, and then increase the illumination to the maximum. Using the joystick, start shifting the focus towards the endothelium. In a normal patient, hexagonal cells are seen adjacent to the bright light. The dull area of 1 millimeter into 2 millimeter adjacent to the bright light is the zone where the endothelial cells are seen. Corneal gattaca appear as large black areas among the endothelial cells. Now, let us look at a photo of how the corneal endothelial cells appear when taken on a slit lamp photography. See, this is the area of the bright light, filament light that you are seeing. Adjacent to this area, in this dull area of about 1 to 1.5 millimeter width and 3 to 4 millimeter length. This is the area where you will see the corneal endothelial cells. It will be usually about 1 to 2 millimeter in size. Look, you can clearly look, all the corneal endothelial cells are hexagonal in shape. They are almost equal in size. This is the endothelium of a healthy patient. Obviously, there are no gattaca which are seen in this photography. Now, let us see the video of how to examine the corneal endothelium. This is the patient which is seated on a slit lamp. We are trying to examine the corneal endothelium of the left eye, and I have tried to take a video of through a iPhone so that we can point out to you how you will be seeing the structure when you are viewing through the slit lamp. Let us see the video. The beam is around 4 millimeters in length and 1 to 1.5 millimeters in the width. This is the filament that is the bright filament of the bulb which is falling onto the cornea, and we are trying to focus our slit lamp being just adjacent to the bright filament. We'll see another video. In this video, see, as soon as the corneal endothelium epithelium is focused, we shift the magnification from 16x to 40x, and then we try to examine the endothelium. This is a little bit tricky procedure, but with practice, you will be able to see the corneal endothelial cells beautifully without a specular microscope, an expensive specular microscope. Happy endothelial viewing. Thank you very much. Thank you. Thanks for a patient hearing.
Thank you, sir. Thank you for such a crisp talk on how to look at the endothelium. This will surely go a long way for the residents to keep seeing more and more endothelium. Thank you. Now I would like to invite Professor Dr. Nagaraju ji to deliver his talk on when to suspect endothelial dysfunction. Please play the next video, Mr. Adhana. Dr. Nagaraju ji.
Good morning, everybody. I would like to thank my colleague, Dr. Shweta, requesting me to be part of this very exciting instruction course on the corneal endothelium. Corneal endothelium is supposed to be the heart of the cornea. If there is an endothelial dysfunction, the entire cornea will fail. The normal crystal clear cornea will become opaque and it will become dysfunctional and will not be able to see everything. So my talk is when do you suspect the cornea is having a endothelium which is not functioning properly. Basically, sometimes the corneal and endothelial function can be subnormal, but still the cornea can be very clear. So such conditions, the patients will be totally asymptomatic. In certain conditions like Fuchs endothelial dystrophy in the early stages, patient can be totally asymptomatic. And as the endothelial cells get lost, what will happen? Patients will complain of more glare, blurred vision, and usually it is due to descent membrane folds and increase in the stromal thickness. And this decreased vision, as the endothelial cell count keeps on reducing, will lead to a lot of discomfort, pain, and there will be rupture of the bullae causing severe photophobia and pain. And long-standing corneal endothelial dysfunction can result in corneal vascularization, corneal blindness, infection, and scarring. In the Western countries, the Fuchs endothelial dystrophy is the commonest cause of corneal endothelial disorder, and this is one of the primary indication of endothelial keratoplasties. Whereas in our country, the primary indication is pseudophakic villus keratopathy and aphakic villus keratopathy. In our country, one of the studies has shown that the most common cause of post-cataract surgery corneal edema is one of the most important cause of endothelial dysfunction, accounting of around 47.9% in secondary to villus keratopathy pseudophakic, aphakic villus keratopathy in around 6% of the cases, and Descemet's detachment in around 1.6% of the cases. Next comes your late endothelial graft failure. That is your post-corneal transplant failure, either due to PK or due to PK, which constitutes around 24% of the cases. Fuchs is the third commonest cause, accounting of around 10.8%. The other causes are posterior polymorphous dystrophy, congenital hereditary endothelial disorders, and ICE syndromes. We should also keep other causes in mind, like blunt trauma, surgery, post-surgery, post-laser. Even a simple peripheral iridotomy for angle closure glaucoma can lead to endothelial dysfunction. Refractory glaucomas, post-infectious endothelial dysfunctions, secondary to commonly due to herpes zoster, and also due to cytomegalovirus. So a thorough history is very important in all the cases. Whenever you see a case of corneal endothelial dysfunction, a thorough history is very important. An accurate slit lamp examination is mandatory in all the cases, and wherever possible, you can confirm your diagnosis by doing a specular microscopy, and the other devices like your UBM and anterior segment OCT high resolution ones will aid in your diagnosis. So this is a case of cataract, which we routinely see in our routine practice. We do a cataract surgery, and this is the result what we expect: a crystal clear cornea with a round pupil, patient seeing better, and you are also feeling comfortable, and all the investigations like this ASOCT showing a normal crystal clear cornea. This is what we usually see. Sometimes sometimes what will happen, a cataract surgery will result in an hazy cornea. What can be the reasons? There are various factors which we have to keep in mind. One is the surgeon's experience itself. A novice surgeon in the initial part of his career might not respect the endothelium very well, and there might be a lot of endothelial cell loss. It has been shown that phacoemulsification and small incision cataract surgery both can cause endothelial cell loss from 6 to 8%, sometimes up to 15% also endothelial cell loss. So primarily it is important to know what is the endothelial cell count in the cornea before cataract surgery. That is, if you got the necessary investigations in all suspected cases, it is better to do a specular, especially if there is a elderly patient with lot of gut and other things. Better to do a specular and find out the endothelial cell count and then take a decision what has to be done. It depends upon the nucleus density. The older the nucleus, phacoemulsification, more phaco time, it can result in endothelial trauma. Intraocular lens placement in ACIOL is in vogue now, but earlier days anterior chamber lens were commonly being implanted following a postcapsular rupture, and that used to result in lot of corneal endothelial decompensation, post-surgical inflammation also. And also patient factors like advanced age, pre-existing Fuchs endothelial dystrophy, which is not recognized preoperatively, previous intraocular surgeries, commonly glaucoma surgeries, and you operate on such patients, patients will be having an endothelial cell loss and history of previous trauma. And those cases where there is a shallow anterior chamber, all these are the risk factors which you should keep in mind. So in the you operate a case and the next day you see something like this. On the left side, you see a cornea wherein the cornea is hazy, and you put the patient on slit lamp and you see the cornea is very thin, but there is a lot of epithelial bedewing. This is because of acute endothelial cell dysfunction, which will recover very fast. If you just give the patient anti-glaucoma medications, the corneal edema and the epithelial bedewing totally disappears. Whereas on the other side, you can see there is a diffuse haze of the cornea. This is called as a striate keratopathy, and this can be, and in this case, the cornea will be thick on an optical section. You do a slit lamp and you can make out whether the cornea is thin or thick. And basically, if it is a thicker cornea, it indicates it is severe endothelial cell dysfunction. So acute corneal edema resolves with treatment of raised intraocular pressure, whereas a striate keratopathy can manifest in varied forms, mild to moderate and severe keratopathy like this. And it depends upon the degree of endothelial cell which were present prior to the surgery and later also. So all cases might not recover also, that you have to keep in mind. And when it resolves, you'll be very happy if you see a cornea like this. And supposing if you see a case like this, or if you try to implant a anterior chamber lens in a case where there is a compromised endothelium, the patient will end up in a corneal edema. The diagram on this side, you can see there is a slightly hazy cornea. This is pseudophakic corneal edema. What are the causes? The main cause is endothelial cell dysfunction, deposition of the fibrotic extracellular matrix, altered matrix metalloproteins, and increased aquaporin levels. This will result in endothelial cell dysfunction. The sodium potassium pump will fail, stromal edema, and long-standing cases will get fibrosis in the subepithelial region, stromal matrix, and posterior collagenous layer. Also, you can see this fibrosis. In such cases, you will not be able to do an endothelial graft. So it is always better and mandatory for you to recognize early corneal endothelial dysfunction as early as possible and try to manage it properly. And this is a specular microscope showing, you see that there is a reduction in the cell density, and there is loss of endothelial cells post cataract surgery. And it has been seen that even a simple peripheral iridotomy in eye with shallow anterior chamber angle closure glaucoma can result in endothelial cell dysfunction. Usually this edema can occur almost up to 5 years, and usually it is common in the Japan, and it is least understood, and it is predominantly common in the inferior cornea far away from the laser peripheral iridotomy site, and it is also seen in those cases where there is a shallow anterior chamber even without an iridotomy also. And post trabeculectomy endothelial cell dysfunction is also very common. Post keratoplasty, late endothelial cell failure, most of the grafts will survive for around 10% of the 10-year survival rate of most of the grafts are around 40 to 80% of the cases, 90% of the cases. And usually this endothelial cell failure can be usually will be associated some immunological rejections, and basically some of them can be subclinical or might not be noticed also. In all cases, put the patient on the slit lamp, look for rejection lines, look for KPs, look for stromal infiltrates, and look for antechamber cells and ciliary injection. And it is mandatory, if you have got the facility, try to do a serial specular microscopy and document everything and note down whether the corneal thickness is increasing over a period of time. That will indicate that there is an endothelial cell failure. And it has been shown that combined endothelium and descemet membrane thickness on anterior segment OCT has a 86% sensitivity and 81% specificity in diagnosing immunological rejection. More than 16 microns is the cutoff value. And this is one of the important latest diagnostic tool which is available for you to make a diagnosis of an immunological rejection. Post keratoplasty, this is a case where you can see there is a endothelial cell dysfunction in a case which has undergone a penetrating keratoplasty, and this is one of our cases which has undergone a descemet detachment following DALK, and there also you can see the endothelial cell dysfunction. You can see the endothelial cell folds there post DALK, and the commonest indication in the Western countries is your Fuchs endothelial dystrophy, and the presence of corneal guttae, and there are various stages of Fuchs endothelial dystrophy. Corneal guttae is one of the predominant feature which you have to look on the slit lamp. And the previous speakers have told you how to examine the corneal endothelium. And you should look for the guttae on the endothelium. And if in the presence of a guttae, you should suspect Fuchs endothelial dystrophy. Do a specular, measure the corneal thickness, and use a cohesive viscoelastic, and try to do an atraumatic cataract surgery if the patient has got a cataract. And in the initial stages of Fuchs endothelial dystrophy, basically most of the cells, endothelial cells, are arrested in the G1 phase. And most of the time it is a late presentation in the 30s or the 50s, sorry, 50s or the 60s. And this late presentation, and it has got a autosomal dominant inheritance, but it has got a very heterogeneous clinical manifestations, and there is incomplete penetrance of the gene. So basically you'll get a wide variety of manifestations. Some of them might be asymptomatic, some might be totally symptomatic. Here you see the various stages of Fuchs endothelial dystrophy. On the right side you see the classical beaten bronze appearance on the endothelium of the cornea. Various stages and various classifications have been described for Fuchs endothelial dystrophy. Basically, you see the guttae. The guttae will be very few numbers or non-confluent in the initial stages. As the stages keeps on increasing, the guttae will become more confluent, and there will be more density of the guttae in the cornea, in the central cornea. Basically, this Fuchs endothelial dystrophy is commonly seen in the exposed palpebral fissure area, most commonly in the inferotemporal area because of the sun exposure. The nasal bridge and other brow will protect the superior cornea and the nasal cornea. And in the initial stages, when the cornea is clear, the guttae are seen, patient is asymptomatic, and over a period of time on specular, they will develop polymegathism and pleomorphism. The endothelial cells decrease, the corneal thickness increases, and you will get corneal edema. Patient will become symptomatic, and long-standing cases, there will be subepithelial scarring also, there will be corneal edema, there will be bullae, rupturing of the bullae, pain, and reduced visual acuity. And these are the various stages, and these are well documented if you see a case. And these are the ideal cases for endothelial keratoplasty if you can pick them early in grade 1 and grade 2. And grade 3, grade 4 stage, you will have to go in for a penetrating keratoplasty only. These are the speculars of Fuchs endothelial dystrophy showing extensive polymegathism, reduced endothelial cell count. You can see the excrescences there. They are the corneal guttae and the specular. And you can see the pleomorphism also. I think all these things have been described in detail by Dr. Tanuja. The guttae, you can see the black excrescences in between the corneal endothelial cells. And some cases, you might not be able to see the endothelial cells at all. And these are the various stages of Fuchs endothelial dystrophy. In the long-standing cases, you'll get something like this, an opaque structure with very few endothelial cells. So what are the other causes of endothelial cell dysfunction you should keep in mind? In infectious conditions like your disciform keratitis, Here you see the corneal edema resolves, but still sometimes you can get an endothelial dysfunction. Usually the commonest virus is the herpes simplex virus, and even cytomegalovirus and herpes zoster virus can also result in post corneal edema, infectious endothelitis. Posterior polymorphous dystrophy is another rare cause of endothelial cell dysfunction, and your eyes syndrome and post-infectious endotheliitis. That is what I described earlier. And uveitis, anterior uveitis, can produce extensive endothelial dysfunction in the acute stage, and if it is not managed properly, can go in for a chronic endothelial cell failure. So it is mandatory for all of us to look at the endothelium. See, basically, when we do an optical section on slit lamp, we just blindly look only at the epithelium, the Bowman's membrane, and the stroma. We usually tend to forget the endothelium at all. Will not be just putting our mind and applying our mind to look at the endothelium. Basically, blindly will be just looking at the anterior part, and if the cornea is very clear, we'll forget to see the endothelium. So it is mandatory for all of us to just do a specular reflection and just have a glimpse of the endothelium, so that we will not have any post-operative surprises, and we'll get very good results post-cataract surgery if we don't miss a endothelial dysfunction. Thank you so much.
Thank you, Dr. Nagaraja sir, for your concise talk on such a practical and a difficult topic. Sir, would you like to give some inputs? Or should we proceed to the next talk and then have the discussion at the end? Okay. Now I would like to invite Dr. Tanuja GP to give a talk on specular microscopy. Abhinav, please play the video.
Hello, everybody. I'm Dr. Tanuja, and I'll be talking about specular microscopy and patients normal and abnormal. Okay, how to read it. So, coming to specular microscopy. So, what is it? It's a clinical specular microscope produces highly magnified images of the corneal endothelial cells, which are normally it's around 100 times, but can vary between 5 to 200. So these high magnification images are analyzed qualitatively and quantitatively using automated software. They help in diagnosing pathology, accurately monitoring and endothelial disease, and also help us in surgical management. So we all know that the endothelial cell on specular reflection, you see it like this. So if this image is then either photographed on a film or transferred to a monitor where it is analyzed by a computer software and a report is given. So before going on to analysis of the report, let's know the types of specular microscope. It can be the non-contact or contact. And in non-contact, the images are, the area image is usually small because the cornea is curved. But in one flow, you can scan both all the central, paracentral, and peripheral corneas. Whereas in contact method, it has to be a systematic manual scanning of each area, and the area imaged is usually large because the cornea is flattened by the contact. The types, there are Conan, Topcon, and Nidex, and all of them give similar kind of reports. Let's see them. Now, what are the techniques of analysis? You also need to understand these, because there can be some variations. We need to understand the nuances of these techniques. Okay, so in either a small frame, which is a fixed frame, which can be fixed or variable, you can immediately see the fallacy if the cells are being taken. The border cells might be wrongly interpreted as either small cells or large cells. And but most of the specular microscopes now use the variable method, so where all the border cells are included in the assessment. So for cell density, the number of cells within this area is counted, and then the cell density is given. To assess the cell area of the cell, it can either be a center to center or a corner method. What do we mean by that? The center from one cell and to the center of the adjacent cells, the area is calculated according to that. Okay, in corner method, the margins are mapped and the cell area is calculated. So you can either way, there's the same thing that I have shown. So in center to center, cells adjacent nuclei are mapped, and in corner points, the corner of the borders of the cells are analyzed and the cell area is given. Before going to reading the image, we need to know the we need to know whether the quality of the image is good, whether it is readable, whether it's a reliable quality. So again, there is some grading. If 96 to 100% of the cells are discernible and very good, it's called excellent. And it keeps reducing. If it's less than 25 to 50%, it's called poor. So the intergrader or intragrader agreement is very high and good in case of excellent and good grades, and falls down with fair and poor. Now, what is the indices that we have to see? This first one is the cell density. So cell density is nothing but number of cells per square millimeter. This cell density is the number of cells that are counted within a particular frame. This CD keeps there reducing with age. So as we see here, just to start to begin with, it will be 3,500, and then keeps on reducing. And after 49 years, it's a bit stable. After that, it drastically reduces, almost reducing 0.6% every year. And always remember that you're going to compare the CD of the particular patient with that of the age expected values. So 1,500 for an 80-year-old might be normal, but not for a 19-year-old. Okay. So any reduction in CD, it has to be compared to the average for the age. So you have to have a red flag for it. So critical CD cell density is around 300 to 600 cells per square meter. Below that, there is a high risk of edema. Patients with CD below 1,000 cells have a high risk of pseudoaphakic bullous keratopathy, almost increases by 14%. What is coefficient of variation? Coefficient of variation represents the amount of radiation in cell size. So it is calculated by standard deviation of the cell area by the mean cell area. So it calculates all the cell areas of all the cells, and they're all charted. And there is a standard deviation which is derived. So if there is a variation from one cell to another, standard deviation will be high. So that means there is polymegathism. A CD of 0.21 to 0.31 is considered abnormal, and any increase 0.31 to 0.4 is considered elevated, and above 0.4 is abnormal. So it is an increased CD is an early sign of endothelial cell disease. X or 6A, some specular microscopes give it as X and some give it as 6A. This is nothing but number of cells that have hexagonal shape. So normally all the cells should have a hexagonal shape. So if there is when there is an endothelial cell loss, the adjacent cells enlarge in size and also lose their shape, lose their hexagonality to cover up the defect. So pleomorphism is also increased pleomorphism is an indication of reduced endothelial barrier function. Normally, I mean, obviously you will expect it to be 100%, not really. In a normal adult, above 60% is normal, but if the hexagonal cells reduce below 50%, it is considered abnormal. Now we also, though those three are the important indicators, you need to know this. The first one will be the number of cells counted. Okay, if the number of cells counted increase, the standard deviation will obviously automatically come down. If the number of cells are less, counted are less, then the SG will automatically go up and the CV will also go up. So first you see what are the number of cells that are counted. Usually it should be at least a minimum of 100 cells should be counted, only then it will be reliable. So here, though the CV is 26 and SG is very high, 316, but the number of cells counted is only 5. So here you will read this particular report with care. You will not jump into conclusions. And with age, obviously there is always an increase in the mean cell area. Average is called as a measurement of average cell area. This number increases with age as polymegathism increases. The number of cells reduce, cell density reduces with age, the mean cell area increases with age. So this is a patient, 32-year-old male patient. Always check the age and see. If you see their number of cells counted is 281 and 285, which is good. You'll say check the number between right and left. There's not much difference. More than 298, you'll be worried, but here it is not. So, and then 32-year-old, it should be between 2,300 to 3,300, which is good. So it is within normal range. Then you will see the CV, which is less than 0.31, the 6A, which is more than 50%. So this is a normal specular microscopy report. So then after that, don't stop there. You will see the images of the cells and see the pattern. So normally the endothelial cell is bright in the center and dark in the boundaries. And there's also a nucleus which is dark in the center. okay, which is just seen as a small dot. When you have to see this, and only then the reading of the report ends. Okay. With normal aging, obviously there is an increase in the mean cell area, but you have to always compare one particular age report with the same age matched values. Okay. Now, what are the abnormal structures that you find? You might either find dark structures or bright structures. So dark structures can be either intracellular or intercellular. Intracellular, there within the cell you will see a black spot, okay, which is larger than the nucleus, so you know it is abnormal. Basically, it is a defect which is not reflecting back light. Okay, so it could be a guttae, which is, and sometimes as the guttae increase inside, the coalesce and the endothelial pattern is not seen. Sometimes you don't see a normal endothelial structure which is bright center and dark periphery. You see a dark center and a bright periphery. Okay, or it can be intercellular dark areas, which are usually inflammatory cells seen in uveitis, or sometimes you can see endothelial cilia can be seen like that. Bright structures are very rare, and they're seen usually after post-keratoplasty. They're hypothesized to be stress cells, or intracellular cells like pigment deposits can also be seen as bright structures. But the most important thing is for you to see these dark structures, which help you in determining the condition. So coming to, we'll see some reports. It's a 56-year-old female patient. This will not be given in your report. You need to know your patient. Okay, you should have examined the cornea, because again, you need to remember that not always the values, the structure and the function do not correlate. So if you have an abnormal structure, that doesn't mean that the cornea should be edematous. So usually there's not a very good correlation between structure and function. Okay, so here it's a 56-year-old cornea. Number of cells counted are very less in this report. So we will examine this with care. The CD is 714 and 610, whereas in a 50-year-old it should be around 2100. The CV is high, 38 and 50, and the 6A is almost 55, reduced, and 33 here. Now, if you see, these are small excrescences, dark excrescences within the cell, okay, which are probably guttae. If you see them in the central cornea, it's more characteristic of Fuchs corneal endothelial dystrophy. So this is another case of Fuchs corneal endothelial dystrophy where the guttae are coalesced, they're large, and there's no endothelial cell discernible there. Okay, here, so there's no pattern, no cells are only counted. So this is though here, if you see CV is 26, but you know this is abnormal cell because only 5 cells are counted. So again, you have to correlate clinically and don't only take the report on its face value. Spectral microscopy plays a very important role in Fuchs corneal endothelial dystrophy. It's very important to know that in Fuchs corneal endothelial dystrophy, guttae are seen in the central cornea in the early stage. So it's if you see guttae in the central cornea, it's very characteristic and pathognomic of Fuchs endothelial dystrophy. These cases, the management also, specular microscopy helps in the management too. If you have a peripheral cell density of greater than 1000 cells per square millimeter, then you can attempt a Descemet's membrane, endothelial Descemet's membrane stripping without endothelial keratoplasty. Or if you are planning for cataract surgery in a patient with Fuchs endothelial dystrophy, you need to know that even about 1000 cells, the patient not necessarily need not have end up in corneal decompensation. So you can still go ahead and do a cataract first. But if it is less than that, then probably it would be wise to do a combined procedure of cataract and endothelial keratoplasty. So here is a 40-year-old male patient with the difference between 2 eyes, right eye and left eye, almost 1000 difference. And the CV is also high in the right compared to the left. And you see here, there's a reversal of the endothelial morphology. There's dark surrounded by light, and there's a rounding of cells. This is characteristic of eye syndrome, okay, iridocorneal endothelial syndrome. Now coming to the next case, a 30-year-old male patient with PPMD, which was diagnosed on SLAM, but specular microscopy only helped us to confirm it. So there are donut shape shaped lesions with surrounding cells almost compressed, and you see that there is a increase in the CV and also a decrease in the 6A, which is only 25%. Keratoconus also has shown changes, especially though we think it's only a stromal or epithelial disease. At the apex, there is elongation of cells and there might be some changes, but if it is very badly affected, then you might the patient might do well with the penetrating keratoplasty. If those are the primary corneal disorders, there are secondary endothelial disorders like endothelial cell loss following intraocular surgeries. It has been shown that any intraocular surgery can lead to some loss of the endothelial cells. Cataract surgery, loss after cataract surgery can vary from 0 to almost 30%. ACIL compared to PCIL has a higher loss in ACIL. Glaucoma surgeries with shunt also have shown to have some endothelial cell loss. Posterior segment surgery, even pneumoretinopexy has been shown to have some endothelial cell loss. Penetrating keratoplasties, there's a continued loss of cells even after penetrating keratoplasty up to 10 years as compared to endothelial keratoplasty, which has only changes up till maybe the first year, and after that it stabilizes. This is a case of pseudophakic billows keratopathy. You see that the CD is 1286. I've been saying there's no structure and functional correlation. So though the CD is 1286, this patient has a pseudophakic billows keratopathy. He has a corneal edema, but the CV is high. The 6A is also very low, and you see a lot of guttae in this patient. So it is so always correlate clinically and then to make a diagnosis. In some cases, specular microscopy like might be helpful to predict or prognosticate corneal edema post-surgery, pseudoexfoliation, diabetes, and chronic kidney diseases. Or some systemic drugs like amantadine used for Parkinsonism also has shown to be to cause some reduction in endothelial cell function. So it might be helpful. Specular microscopy will help in following up these patients. Not all of them, not all dark structures that you see are guttae. Sometimes endothelial inflammatory cells on the endothelium can be seen as the dark spots. But if you correlate clinically, you see keratic respirates over those areas, and if you treat them and once they disappear, the cells, the endothelium becomes normal. So these are pseudo guttata. So the take-home message will be how to read the specular microscopy report. First, see the CD correlate with the age match levels. See the difference between the two eyes. Is there a difference of more than 280 between the two eyes? A coefficient of variation of greater than 0.4, or a 6A or a hexagonal cells of less than 50%. So you need to be aware that these can be abnormal. And after evaluating any case of post-operative corneas, just don't take only one particular image, only the center. You should always take from central, mid, periphery, and even periphery, because regional disparity is known post surgeries, and that will help us in giving the average and prognosticating the cases. Thank you very much.
Thank you, Dr. Tanuja, for your excellent talk on specular microscopy. It will definitely help in the analysis of the specular microscopy charts, what to look for, how to look for the endothelial cells, and how not to rely only on the charts and focus on the clinical findings. Thank you, ma'am. Now I'll be speaking on smartphone endothelial cell layer photography. I'll be sharing my screen as I was not able to upload the talk because of its high mode size. At the outset, I would like to thank Karnataka Ophthalmic Society for giving me this opportunity to speak about a smartphone endothelial cell layer photography. In this talk, I would like to introduce you to a new low-cost technique of endothelial cell layer photography that is smartphone-based. There is no financial interest. Smartphones have replaced alarm clocks, cameras, or daily use calculators, and they are finding its footprints in healthcare also. The assumed number of smartphone users in the world in 2012 was 1 billion, and it increased to 1.75 billion in 2014. Medical applications make smartphone tools in the practice of evidence-based medicine, mobile clinical communication, patient education, and remote patient monitoring. So what are the uses of smartphones in ophthalmology?
Shweta,
So it is,
you can't see,
yeah,
your slides are not moving.
slides are not moving.
Yeah.
Just a minute. Are you able to see the screen? It's only the first slide, is it?
Now I think it is moving.
Is it visible?
Now,
Yeah.
yeah, now we can
Visible.
see, but it is just stuck there.
Okay, okay. Is it visible now, ma'am?
Yeah, it is visible, but it's stuck in that color vision screen.
Okay.
Yeah. Right.
Yeah, yeah. I have not moved the slide.
Okay.
Yeah. Okay. So it is finding its application in the assessment of color vision, astigmatism, words, four-dot test, accommodation targets, red desaturation test, Amsler grid, OK and drum, fundus photograph, subjective refraction correction, patient education visual aids, and also in research there are apps like PubMed on tap, Medscape, Epocrates, and UpToDate. So this technique of endothelial cell layer photography is not novel. It has been in existence since many years. This endothelial cell layer was photographed with the help of a camera attached to a slit lamp, but the access is very difficult. What is novel here is the use of a smartphone to photograph the endothelium. As Dr. Tanuja has elaborated about the specular microscope, its uses, it gives an excellent analysis of the endothelium, the count, the coefficient of variation, the pleomorphism, the polymagatism. But there are a few limitations. It requires a regular electric supply, a separate computer with operating system. It is less accessible or feasible in low resource or low surgical volume settings, and the cost is prohibitive. And it also requires a huge space. Why smartphone endothelial cell photography? It is battery powered, it is portable and rechargeable, and it contains both hardware and software in one package. And there is an easy access. So it is a good candidate for development of imaging technology for wide distribution. Smartphones have become part and
Dr.
parcel of
Shweta,
life.
sorry to interrupt. Dr. Shweta, your
Yes,
slides
ma'am?
are really not moving actually.
Oh, okay. Which slide are you seeing now, ma'am? Conventional specular microscopy?
No, the color vision, astigmatism.
Fifth slide. Fifth slide.
Just a minute.
Now it has moved. Now it has moved. Yeah.
Okay, I'll do the presentation from this one, this screen only. I think there's problem with the slideshow. Is that okay? Yeah.
Okay.
Okay.
No problem.
It should be okay, but it is, you just move it.
I think now you should be able to see. Is it? Is it visible now?
Yeah. Yeah.
Yeah, now it's
yes.
visible.
Yeah. Thank you. So it is a good candidate for development of imaging technology for a wide distribution. So we have been glued to smartphones in our daily life. So technology, we always have to make better use of it. So this is one of the productive ways of technology. So what are the requirements? A smartphone, which is there with almost everyone now. You need not have a high-end smartphone. A low-end smartphone or a mid-range smartphone should do the purpose. A 16 megapixel rear camera with a minimum of 6 times digital magnification will do an excellent job in photographing the endothelium. A slit lamp with a bright illumination and a good magnification. You can use an adapter. It will make your job easy, and the quality of images will also be good because of the less shake or the blur in the images. You should be well versed in doing a specular reflection. That is why we have emphasized how to do a specular reflection in the beginning of this course. An interest in photography and some experience in anterior segment photography will go a long way in photographing the endothelium. You definitely need a good cooperative subject or a patient in the first few days of photographing the endothelium, because it really requires a minimum of 3 minutes in front of the slit lamp to now for the patient has to be stable. He should not move his head, should not move his eyes, because we are taking this images at a magnification of slit lamp magnification of 40x and a digital magnification of 6x. So a small movement also will distort the images. So at least a minimum of 2 minutes, 2.5 minutes for both eyes put together, you can learn. So there is already existing literature, but not much. Shrikar Mantana et al. Have published a study based on smartphone-based specular imaging and automated analysis of the corneal endothelium. They have made use of an iPhone attached to an adapter, took a video and took frames of the video and edited it. And by using various algorithms like a KH algorithm, grayscale conversion, and segmentation, they have calculated the cell area of the slit lamp image and calculated the number of cells. And they have found that the number of cells, the endothelial cell density, what they have calculated by this is comparable to the specular microscopy images. They have a corneal imaging app, though it is not put for public use till now. Maybe we can expect that app in the future. So an app-based analysis will even more emphasize and bring more importance to smartphone endothelial photography. And Devrim Toslak et al. Have also published a smartphone-based imaging of the corneal endothelium at subcellular resolution. They have also used a smartphone and a Microsoft Word Paint. They have used these images and put it on Paint and done some editing and calculated the cell area. But there is no comparison between the specular microscope and the images that they have taken. So this is how we have done this smartphone endothelial cell layer photography. So the patient should be seated comfortably. He should understand the procedure well. And this is the decentering of the beam. So the slit lamp, what we have used is a Carl Zeiss 5-step slit lamp. There's no financial interest. So it has 40x magnification, but at 25x magnification, you should be able to see the endothelium. But to photograph, a 40x will do an excellent job. So this is the decentering of the beam. This is the viewing beam. This is the illumination beam. It is almost at 50 to 60 degrees. So to play the video, is the video playing for you? I know.
Yes, it's playing.
Yes. So this is just a handheld smartphone. Here you have to see that your hands have to be stable. The ring finger and the middle finger has to rest on the eyepiece, and your index finger has to rest on the edge of the smartphone and the thumb at the lower edge of the smartphone. This is very important to get a good image without any blur. Your right hand should be free to take the images. So this is how. So this is done with a normal, this is not a very ultra high definition or high definition video. This is just a normal video. We have put the slit lamp magnification at 40x and this digital magnification. So this is how you focus. You identify that circle of light, then zoom, look at the bulb filament, identify the epithelium and the endothelium. Sorry, the video is slightly upside down. You cannot edit it. Identify the filament, the reflection, and look at the area adjacent to the bulb. And now the digital magnification is at 6x. If you increase the magnification, the resolution decreases. Better to have a 6x magnification. Adjust the brightness as and when you can adjust the button where you click the photograph just next to the slit beam so that it is easier for you. It is easier for the dexterity. So this is the gross view, how to look at the bulb image and where to focus the light, where to see. As you can see, there are already few cells visible there. So in the next video, we'll be showing how exactly the endothelial cells are looking. See now, this patient, the size of cells is definitely high, as you can see. So this is the reflection of the bulb. Then this is the area where we have to be looking at. So this is the sheet of cells. This patient had 2 prior intraocular surgeries. So there is an increase in the size of the endothelium and a reduced cell count. This is a compensatory polymegathism of the corneal endothelium. So again, another video. This is at a higher magnification. So you can also look at the epithelium on specular reflection. You look at the cells, the cell borders. Okay, this is how we took the video. You can also take a photograph, just a photograph. So this is of another patient, a 12-year-old boy with keratoconus. You can see the density of the cells here. Compare this with the previous video where there were enlarged cells, and here there is a beautiful sheet of cells arranged. You don't see any polymegathism here. So this is a shot on the smartphone. You can definitely take frames from the video or directly take the photo image. So this is a slight comparison of the images of the same patient wherein a specular microscopy was done, and this is the endothelial cell layer photography. There is no editing done in the right hand picture. We can do the editing, like we can cut the borders here, take only this frame. As Dr. Tanuja told, how do we do a frame method of counting the endothelial cells? Take a frame and count the numbers of cells. There is no application as to how to, you can manually dot the cells. These are tried, but there is no definitive estimation of this till now. There's only one app which is not still in public use. So this is the comparative picture. So this is from the specular microscope, and this is from the endothelial photograph by smartphone. So these are the few pictures that we took. So this is the bulb filament. This is at a higher magnification, and this is at lower brightness. It is very bright here. This is also bright, and this is at a lesser brightness. So the cell borders are enhanced here. These are a few pictures. So this is a photograph of that boy which I showed you in the video. The keratoconus. You see the density of cells in such a small area. It is the cornea of a 12-year-old. So this is the appearance of beaten metal appearance in Fuchs endothelial dystrophy, where we could not exactly visualize the endothelium both on specular microscopy and on endothelial cell photography. So this was the beaten metal appearance. But you have to go through all these type of images if you have to take such good images. These three images are in the first 25 to 30 attempts of taking the photograph. So you need to have lots of patience. This is in the next 50 attempts. So now the borders are slightly visible. You can make out that you're doing specular reflection. It has also got its limitations. It has got a steep learning curve. You need to have a good access to a slit lamp and patient's data privacy as in any smartphone healthcare application. Thank you. Smartphone endothelium photography is difficult, but very much possible. Thank you. Thank you for your patient listening. I thank Professor Dr. T.K. Ramesh sir for joining this instruction course. Now I would like to invite Dr. Hari Prasad to speak on recent advances in endothelial regeneration. Kindly play the video, Mr. Abhinav.
Hello, everybody. At the outset, I'd like to thank Scientific Committee COSCON for giving me this opportunity. Today, I'll be talking about recent advances in the management of corneal endothelial dysfunction. Corneal transplant is still the gold standard to treat endothelial dysfunction. It can be full thickness or just a posterior lamellar graft. But they have issues like rejection, failure, graft infection, or poor quality of vision after the treatment due to high irregular astigmatism. In cases of posterior lamellar keratoplasty, issues like repeated dislocation of the graft is also seen. And these have a steep learning curve for the surgeon. So that's why newer approaches are being developed to treat corneal endothelial dysfunction. They can be endothelial cell-based approaches, stem cell-based approaches, pharmacological intervention, and surgical intervention. In cell-based approaches, Dystrophy membrane along with endothelial cell from cadaveric donor cornea is harvested. Then they are treated enzymatically so as to allow for isolation of endothelial cell, which are then collected, plated onto culture media with growth factors. It is then allowed to expand in number over a period of time. It is then harvested to use to treat multiple patients rather than the usual 1:1 ratio. Then you have to deliver it to the patient's eye. It can be done in two ways. One is injection therapy, and then is scaffold-based carrier systems. Coming to culture cell injection, which was pioneered by Kinoshita and his colleagues in Japan. He described a procedure where patient's damaged endothelium is scraped off, leaving behind the Dystrophy membrane. The point to be noted here is only the endothelium is removed, not the Dystrophy membrane. Once it is done, you inject the culture endothelium cells into the anterior chamber. And the patient has to lie down in prone position for 3 hours so as to allow for the culture endothelial cells to attach onto the patient's Dystrophy membrane. Very recently, a study published in Ophthalmology journal reported a 5-year follow-up of 11 patients who were treated with cultured endothelial cell injection in a first ever human study. The results were quite promising. They showed that best corrective vision acuity was significantly improved in 10 treated eyes, and there was no adverse reaction. This procedure is useful only in mild to moderate cases of endothelial dysfunction. Patients with DM scarring or severe gut is not ideal. Coming to scaffold-based tissue engineered graft, here cultured cells are combined with the biomaterial so as to create a tissue engineered graft, which is then used for transplantation. So after isolating and expanding the endothelial cell in a culture plate, they are then seeded onto a scaffold so as to allow the endothelial cell to form a confluent monolayer before it is transplanted into the patient's eye. So what this scaffold does is it helps in favorable expansion as well as production of a robust endothelial tissue, which can be then handled without any difficulty for transplantation. So basically, this scaffold mimics the function of a Dystrophy membrane. Once you create this scaffold, multiple grafts can then be produced, which can be then used to treat multiple patients. These scaffolds can be biological, like amniotic membrane or human lens capsule. It can be semi-synthetic, like gelatin and chitosan. It can be synthetic, like hydrogel or PMMA material. Recently, 3D bioprinting is also used in scaffold tissue engineered graft. So basically here, the culture endothelial cells are loaded onto the 3D bioprinter. Then designs are generated in the computer, and this commands the bioprinter to print the cells on a scaffold like amniotic membrane. Once it is done, it is then transplanted to the patient's eye. Coming to stem cell based treatment, as you all know, corneal endothelial cells are embryologically derived from neural crest, and investigators have successfully produced corneal endothelium like cells differentiated from dermal fibroblast, adipose tissue, and bone marrow of human beings. So the advantage here is the ability to use non-ocular autologous cells from the same patient who have ocular problems like corneal endothelial dysfunction. Since it is autologous, chance of rejection is minimized, and they don't face the ethical issue as in case of embryonic stem cell transplant. But since they are also pluripotent, chances of teratogenesis is common. And the whole differentiation process is complex, and till date, no standard protocol has been developed. Coming to genetic treatment, in cases of Fuchs endothelial dystrophy, there is a specific genetic mutation which causes the disease. So if you can identify the specific genetic defect, you can potentially develop a very specific intervention to it. So in the future, intervention might include genomic editing strategies at the DNA level using the CRISPR system, or interventions can be developed at the messenger RNA level using antisense oligonucleotides. Coming to pharmacological treatment, cellular stresses on corneal endothelium like inflammation, trauma, free radicals will activate the ROCK phosphorylation pathway, which then decreases cell adhesion, cell proliferation, and also activates apoptosis of corneal endothelium. So inhibiting this ROCK signaling pathway has been shown to promote cell adhesion, cell proliferation, and also inhibit apoptosis in cultivated human endothelial cells. So right now, commercially, you have a ROCK inhibitor called ripasudil, which is available in 0.04%. It can be either used topically in a patient with corneal endothelial dysfunction, or also this ROCK inhibitor can be used in endothelial cell culture to promote cell adhesion and proliferation. Coming to the last topic, which is surgical techniques in regenerative medicine. It can be despite stripping only and despite membrane transplantation. In despite stripping only, the diseased endothelium along with despite membrane in the central cornea of the patient is removed, which then allows the healthy peripheral endothelial cells to migrate centrally and redistribute, thereby restoring the endothelial function. Point to be noted here is only the central 4 mm of the diseased DM is stripped, not more than that. Coming to despite membrane transplantation, here the host DM is stripped and then you prepare the donor graft by removing the endothelial cells mechanically by using a silicone tipped cannula, and this despite membrane graft is then inserted into the patient's eye by any standard DMEC surgery protocol. Since this DM is acellular, chance of immunological rejection is very less, and also long-term medication is not necessary. And also for the graft, you need not use any optical grade corneas. You can also use therapeutic grade or poor quality corneas. So finally, to conclude, I would say that despite being effective in reversing corneal blindness, the conventional corneal transplant techniques are donor dependent, and most probably in the future will be replaced by novel alternatives like endothelial based therapies and regenerative medications. But further research and clinical trials are required to improve specific therapeutic techniques and also to determine the long-term safety and efficacy of each of the novel therapies. Thank you.
Thank you, Dr. Hariprasad, for highlighting the recent advances. We are already beyond our time limit, but if there are any questions or inputs quickly. There are no questions in the chat box.
Yeah. Dr. Shweta, in your presentation, I saw, really good photographs being taken of the endothelium, which was
Thank you.
as similar as the specular microscope photography. And I noticed that, most of the photos were taken on Samsung phones.
Yeah.
Samsung phones usually have multiple cameras. So how do you, is there a way to clearly focus? Is there a way to avoid the secondary cameras or primary cameras? How do you take it?
No, the one which is closest to the slit lamp, the uppermost part of the camera, you just focus. Though it's the quad camera, the uppermost part of the one which comes into the focus, you just focus it. There is no way where there is no setting change. How you take the external photography, it is the same.
Okay, but if there are, I mean, 3 or 4 multiple cameras, I mean, which camera you try to
Mul-
focus?
No, you can, that's what, the one which is closest to the eyepiece of the slit lamp, the upper top left, top left one
Okay,
in the quad
anyone, I
camera.
mean, anyone you say, I mean, not the
The
primary,
primary camera. Yeah, the
primary
primary
camera.
camera.
And how do you know
Yeah,
that it's
yeah.
a primary camera? We don't know, right?
In the settings, you will
There-
know. If you want to know
okay,
whether it's
okay.
primary or secondary, if you see the settings, you will know that it is primary or secondary.
Okay, yeah, yeah. Fine. I mean, I don't have much of an experience using mobile slit
Yeah,
lamp
yeah.
photography. That's why I asked. I mean, I would like to know the experience of any speaker who have used rock inhibitors. I mean, is it really effective as they claim, or how is the patient response to it?
Yeah. Dr. Hariprasad, I think the speakers for the next session have already joined in. If we can have the elaborate discussion, probably the date, I think.
Yeah,
If
sure.
anybody interested, you can definitely call me. I will let
Sure,
you know.
sure.
Yeah. Thank you all the instructors of the course for your valuable time and for your patience. And I thank Dr. Ilan Kumar as our committee chairman for giving this opportunity. Thank you so much.